the invitation. So Dr. Saeed already discussed part of epidemiology, and so actually I can probably skip that part. So I'll probably more focus on de-escalation, work on escalation treatment in HPV positive, actually P16 positive oropharyngeal carcinoma. No financial conflict to declare. So this slide usually show, I just want to say that really nowadays 80% of our oropharyngeal cancer patients are all HPV positive cancer, maybe even higher now. So really the two HPV and HPV positive and HPV negative cancers are really two distinct entities nowadays, we know. As Dr. Saeed already mentioned quite a bit, but I just want to point out that the cause of diseases is different now. For HPV negative disease, usually is from tobacco, alcohol use, whereas HPV positive disease now it's considered as a sexually transmitted disease. And usually the patients are younger and better educated, so they're in higher social economic status as compared to HPV negative patients. So this just shows that prognosis is different, HPV negative disease versus HPV positive disease. I just want to point out this this one here, the SEER data are really interesting, that over time, so the axis is a median survival, and look at the patients treated over a different period of time, from the 80s to 2004, probably now it's even better. So you look at the median survival, really has increased quite a bit over 2 decades. So if you only look at this and say, we had made really nice progress by doing better treatment, right? So better diagnosis and better intervention. But turn out that's not the case, and because now if you look at the median survival for HPV positive disease, that's where we made really major impact. Whereas HPV negative disease over the last 2 decades, really that's not much progress has been made. So I think the overall survival benefits, and actually overall better survival over time, really is because we're dealing with a different disease nowadays. And Dr. Saeed already showed this one, and basically we can actually divide oropharyngeal cancer into 3 categories depending upon the level of risk: high, intermediate, and low risk. So that comes down to the concept of de-escalation, because first of all, HPV cancer patients, they're young, and also HPV disease is highly radiosensitive, and prognosis is good. So when you're dealing with young patients with excellent prognosis, then you really have to pay attention to not only the chance of a cure, but also overall quality of life, especially the swallowing function, for instance, xerostomia, dry mouth, and overall function. So compared to HPV negative disease, because the fact patients are younger, we are seeing more and more delayed complications. Unfortunately, that happens, and if you follow patients long enough, we do see complications that can happen even years after the radiation treatment. So the goal of de-escalation, the treatment of for HPV positive oropharyngeal cancer, really is to develop a less toxic strategies while maintaining good oncologic outcomes. That actually is very, very important, because if we can cure a lot of patients by standard treatment, if you try to do anything less, the first goal is to make sure you're not actually compromise the chance of a cure. So the outcome is important. So nowadays we're looking at 2 outcomes: the overall chance of a cure, which we know is very good, but now we're looking at the quality of life functions. So there are 4, actually mainly 3 main strategies in de-escalation, the intensification in HPV positive oropharyngeal cancer. I just want to limit it and actually list this few, and I'll go over several representative trials. Most actually have not been published yet. So one strategy is Dr. Saeed just introduced, basically doing robotic resection, which is considered de-intensified surgery. And because they don't do open resection, composite resection, they do actually robotic resection, so that's morbid. So try to use that strategy to de-escalate the chemotherapy and the radiation. The second strategy is to de-escalate, actually de-intensify the chemotherapy. As we know standard treatment for most oropharyngeal cancer patients really is concurrent chemoradiation therapy. So the question is, can we do less chemotherapy to hopefully reduce some complications or at least acute side effects? So there are several major trials. The largest ones are RTOG, 1016, this been reported, and also de-escalate European study also been reported by doing less toxic systemic therapy such as cetuximab. So the third strategy is to reduce the intensity of radiation therapy by even doing less radiation or by doing induction chemotherapy, depending upon response, then you can actually give a less dose radiation therapy. So this is a scheme actually I want to go over. So basically, if you look at oropharyngeal cancer, there really you should treat this oropharyngeal cancer differently depending upon HPV status. So for HPV positive disease, the work really is focused on de-escalation, right? There are four strategies. We'll go over that with you. And also for HPV negative disease, actually we'll go the other way. Actually, we have to escalate the treatment because as I show you previous slide, for HPV negative disease, we have not made any progress over the last 2 decades or 3 decades. So for each strategy, and I'm going to go over very important trials, and some actually being reported, some are actually still work in progress. So the question is, can we improve a function by reducing treatment morbidity while maintaining oncologic outcome? So the first trial is ECOG study 1308. Actually, this is the first trial designed mainly by medical oncologists. Actually, we have to give them credit because they jumped in this concept very early. So what they were trying to do in the ECOG 1308 is by introducing induction chemotherapy, hoping they can select the patients that may respond to radiation better. For those patients, you don't have to give a high dose radiation. So basically, it's induction chemotherapy using that as a biomarker for radiosensitivity. So the study design is in such way, give upfront chemotherapy, cisplatin and Taxol with the cetuximab, and then depending upon response, right? You reevaluate after 3 cycles. The patient had a complete response. Then you give a low dose radiation, 54 gray with weekly cetuximab. Now, patient has less than CR, then you do standard treatment, which means 7,000 centigrade. Actually, it's actually 33 fractions with cetuximab. So this study, as you can see, ideally you go this way, then you de-escalate treatment. But in reality, this study actually is not true de-escalation, right? Because by introducing aggressive systemic therapy, also you give end up doing all 3 modalities: cisplatin, high dose radiation, and cetuximab. So this study has been reported actually at JCO. And so the endpoint really is 2-year progression-free survival. So there's a 85% was said. Anything less than 85% they consider as not acceptable because we would expect at least the progression-free survival at 2 years to be 85% based on what we know about HPV positive oropharyngeal cancer. So this is the result. Unfortunately, this study was negative because the 2-year PFS was only 80%, despite very high CR rate at the primary and a CR rate at the node. So remember, those patients will receive 54 grade. So, but obviously, if you break down, see why those patients, failed. For the most part, the patient actually had more than 10 pack years smoking history, and most patients had either T4 or N2C disease. But nonetheless, the study, unfortunately, was a negative study. So which means just based on this study, that strategy probably is not the best, induction chemotherapy followed by reduced radiation. So this is the interpretation. And even though the concept is good, right? So use this as a biomarker, you can select patients that would respond to radiation better, and you don't have to give a high dose radiation therapy. And so this is the problem really is that this study was not a true de-escalation because they ended up doing all three, and chemotherapy, radiation, and target therapy. And this is actually also important. They say, well, despite a complete response, 54 grade is still not adequate because of very high risk of a local regional recurrence up to 30–35%. But nonetheless, the low dose radiation reduce the long-term complications, especially swallowing. So the second strategy is designed by radiation oncologists, obvious, right? So RTOG and also de-escalate. So what we're trying to do is we'll try to de-escalate the chemotherapy or de-escalate systemic therapy by introducing what we consider as a less toxic systemic therapy, which is cetuximab, because for a long time, we believed that the cetuximab was easier, it's better tolerated, is less toxic. So now RTOG say, well, can we replace the cisplatin by giving less toxic systemic therapy, which is cetuximab? And the European study also did the same study, similar design called de-escalate, and the TROC study also had similar designs. So basically 2 arms. The standard arm is the IMRT 7,000 centigrade, giving 6 fractions, 6 weeks. So which is 6 fractions per week. Then give a high dose chemotherapy, but just 2 weeks. I mean, 2 doses cisplatin chemotherapy. So basically, you accelerate radiation therapy a little bit, and by then the experimental arm is radiation therapy, 7,000 6 weeks plus cetuximab with loading dose upfront. And so what's the outcome? It's just been reported last December, Lancet, and the de-escalate study was reported a little bit before this. But since this study has the largest patient number, so I want to just go over this very briefly. So this study design was non-inferiority design to just say the cetuximab was not inferior to standard cisplatin chemotherapy. So it turned out actually this is a big surprise, very disappointing that if you look at the survival, overall survival, the cisplatin with radiation therapy, was better. That was statistically significant in terms of overall survival. So survival rate, we're looking at 84 versus 77%. And so if you look at the forestry, all these parameters, they all suggest actually cetuximab was inferior. And also the progression-free survival, cisplatin is much better than cetuximab, and the local control is also superior, when you give standard chemotherapy. So what about the toxicity? Because the main reason to give a cetuximab is try to reduce the severe toxicity from cisplatin. So it turned out actually the toxicity is not much different. Essentially it's the same, especially long-term toxicity, there are actually no difference. So the study really is a wake-up call, is that when we try to do anything less, and so this is something you try to avoid. First of all, you compromise overall survival, but also you did not actually reduce the toxicity. So that's why now cetuximab is no longer considered as treatment for HPV positive disease. And so this is a summary from that study. So radiation plus cisplatin remains the standard of care. We need to find a better way to reduce or get rid of chemotherapy. So the third strategy is using de-intensified surgery, which is transoral resection, robotic resection, try to de-escalate the radiation and possibly de-escalate the chemotherapy as well. So this is a study, quite a complicated design. We'll go over that with you just in a minute. So the ECOG 3311. So this is a study design. So HPV house patients, if a patient is eligible for transoral resection, and then you do the transoral resection, then look at the pathology. Then you have a low, intermediate, and high risk. Low risk means if a T1, T2, N0, N1 negative margin, no ECE, extracapsular extension, then those patients you observe. Now, intermediate risk group is patient who has ECE, but less than 1 millimeter and less than 4 positive nodes and PNOI, LVOI. For those patients, you randomize to low dose radiation 5,000 centigrade in 25 fractions versus standard radiation 6,000 in 30 fractions, which is standard post-op radiation therapy. Now, for high-risk patients, positive margin, ECE larger than 1 millimeter, more than 5 nodes, now you do standard post-op chemoradiation therapy, 66 grade 33 fractions with weekly chemotherapy. This study has not been reported. Really, this is from a meeting just very recently. So this really considers a very, very early interim analysis. So far, there has been no difference between each arm. So we have to wait until this study has been reported. So the third strategy is what actually we really like, at least at the beginning, called NRG 002, which actually which is a randomized but phase 2 study, phase 2 randomized study. So both arms are a de-escalated regimen, and so what are those arms? So the first arm is a 60 gray in 6 weeks. With weekly chemotherapy. The second arm is 60 gray in 5 weeks, but the radiation only. So you see, both arms are not considered as a standard, but both arms are de-escalated. So again, the endpoint is 85% PFS at 2 years. So first of all, toxicity. So yes, chemoradiation therapy did increase the grade 3 acute toxicity, mainly hematologic, and but if you look at the long-term, grade 3, grade 4 toxicity, really there's no difference whether you give a chemoradiation therapy or radiation. So this is the overall survival. So overall survival is essentially the same, right? So, and at 2 years, 96 versus 97%. So they were really good overall survival. And however, if you look at the primary endpoint, because the preset primary endpoint is 85% PFS at 2 years. And so chemoradiation arm actually met the endpoint, not radiation therapy alone arm, because this was statistically significant and radiation alone was not, which means at least based on this study, the chemoradiation was the winner. And if you look at the local control and distant metastases, the radiation alone arm did have a higher risk of a local recurrence. And of course, this study also looked at a function called the MDATI, so the MD Anderson dysphagia index, and basically there's no difference. So which means the chemoradiation therapy with IMRT had a better PFS, but also no difference in terms of swollen function. So because of that, so this study was considered as maybe chemoradiation therapy was considered as again preferred, and the standard should be remains standard. And so there's no difference in terms of long-term toxicity by doing locally chemoradiation therapy. So now this is the current study, look at the difference, try to look at can we use the immunotherapy to further improve the outcome. So basically at this point, so there are low and intermediate and high risk. So we know for low risk, it's very safe to do de-escalation. For moderate risk, we don't know how to do it. For high risk patients, actually we have to escalate. So I want to just point out there's one study, two studies looking at escalation treatment with the surgery followed by chemoradiation therapy, the high dose, low dose, high dose radiation, basically intensified treatment. There's another study to intensify treatment looking at the surgery followed by radiation, low dose, intermediate dose, and with immunotherapy. Because the main metastasis, distant metastasis remains the main risk of recurrence. So that's why nowadays of this study try to introduce induction immunotherapy followed by surgery and followed by chemoradiation therapy with immunotherapy. So really escalation. So in summary, we know HPV-mediated oropharyngeal cancer is a really different entity now, has better prognosis, and the incidence is rising. So it is sensitive to treatment. It's really important to be able to figure out how we can do less to have less complications, have better quality of life. So many studies are still, clinical trials still ongoing, and the results are waited. Thank you.
Thank you, Dr. Zhen. Our next